Well, thanks for coming back. I know you see research in the presentation, and many of you may be wanting to run the other way. I promise this is not going to be boring, and I'm not going to show tons of graphs. I have just 2 graphs. But what is meant by this is just to give you an overview of the research that's been conducted. We've said a lot already about the fact that PCIT is evidence-based. Hopefully we've convinced many of you already, but I'm going to try to convince you even more by actually talking about some of the studies that have been conducted on PCIT and some of the different populations PCIT has been applied to, which are some of the questions that came up in the previous talk. This is not by any means an exhaustive list of the research that's been done on PCIT, so if you are interested in a more exhaustive list, then if you go to the website, which Melanie just posted before, www.pcit.org, there's actually a database that we put together that we probably need to update soon that literally lists every single study that's been conducted about PCIT, related to PCIT, and so it's a great resource for any of you, and it'll have links to those articles, the abstracts on PubMed, and et cetera. Okay? So let's get started. So PCIT, as Melanie talked a little bit about, is deemed an evidence-based treatment by Division 53, which is in part sponsoring this series of workshops. And that was from a result of 2 different journal series in 1998 and then again in 2008, where authors, Sheila and Melanie being 2 of them, wrote about evidence-based treatments for disruptive behavior disorders, and PCIT was listed as one of those efficacious treatments. It was considered a probably efficacious treatment in that report. And so Division 53 considers it an evidence-based treatment. We also have some data I'll talk briefly about on working with families who have physically abused their child and working on reducing the reoccurrence of abuse. And based on those findings, we have support from the National Child Traumatic Stress Network, showing that, demonstrating, essentially saying that this is an evidence-based treatment that can be used to help with families who have undergone those kinds of situations. And then I'm not going to exhaust through this list, but as you can see, a lot of other organizations have identified and deemed PCIT as an evidence-based model, a model program that we should use, particularly when talking about young preschool-age children. Okay? All right, so let's get into the details of the studies. So the efficacy of PCIT. So what we mean by the efficacy is, did PCIT work in a research clinical setting in a very strict randomized trial where families are randomly assigned to either receive treatment or not receive treatment or receive some kind of control treatment? And that's generally how we can, from a statistical standpoint, say that this treatment is effective. This is effective relative to no treatment. So we typically report 2 main randomized trials that were conducted, one in the United States and one in Australia. The Schumann et al. Was part of Dr. Iberg's team, and then the Nixon et al. Is part of the Australian team. Both studies were fairly similar. They were both randomized trials, and families in both studies were randomly assigned to either receive PCIT or be in a waitlist control group for the time that it takes for families to receive PCIT, so we can compare them. The Australian study actually also had a brief abbreviated version of PCIT that also fared fairly well. So that is a little bit of a difference there, but for the most part, they were looking at the main effect of standard PCIT relative to a waitlist group. So in these studies, the kids, and this is highlighting some of the things that Melanie was talking about previously, the kids were 3 to 6 years old in the Schumann study. They were actually 3 to 5 years old in the Nixon study, in the Australian study, but around the same age, preschool age. All were diagnosed with a disruptive behavior disorder, either oppositional defiant disorder or conduct disorder. Of course, we know with those diagnoses, there's a lot of comorbidity. So many of the children also had ADHD or may have also had an anxiety disorder, but they were referred primarily for those conduct problems. They were also primarily Caucasian and middle-class families, and this is something I'll get into a little bit later in terms of some of the other research being done, and I imagine many of you who are working in the community are not seeing the kinds of families that were seen in this initial randomized trials. So we'll talk about that as well. Also of note, children and the parent, the primary caregiver in both of these studies, were screened out if they were delayed, developmentally delayed. So we gave the folks in these studies gave IQ screeners or language screeners for the child, brief screeners to see if the child has a potential developmental delay. And if the children scored below a 70 or the parents scored below a 70 on that screener, then they were not included in the study. Okay? So in terms of the outcomes for these two main randomized trials, we saw really exciting results, really neat findings, both in terms of the child behavior. And when we say the child's behavior improved, it didn't just improve by asking the parents on their questionnaires. So they improved because the parents' report of the child's behavior improved on these questionnaires, but also in both studies, there were coders that did not know which families received treatment and which families did not receive treatment. And they observed the children in play situations with their parent, in particular in cleanup, when the parent told the child to do many things and clean up the toys. And those children that received treatment were significantly more compliant of those children that received treatment than compared to the children that did not receive treatment. So these are based on objective reporters, coders that did not know which group families were in. Okay? We also have evidence from these studies that parents report reduced levels of parenting stress following treatment relative to the waitlist group. And also they report more effective parenting practices. So they're saying they're doing things that we're trying to teach them. They're saying they're being more consistent. They're spending more quality time with their children. Okay? So the findings are really compelling. The other thing to highlight, so this is my one graph, so count that as my one. I have one more. In this graph, this is one of the outcomes from the Schumann study, where you can see in red, those are the families that were in the waitlist group. And then in blue, those are the families that received PCIT. And then this is the initial assessment, and then this is following PCIT or following that waitlist group. So you can see just visually the dramatic difference, right? But we know we could be really fancy on graphs and make it look better than it might be. We're not actually doing that. So this is also statistically significant. The p is less than 0.001, and that's kind of the magic bullet for getting things published. But more meaningful is this thing called D underneath the p-value. And what that means is that's the effect size of this treatment. And when we say effect size, what we mean is the magnitude, the strength of the effect of the intervention. How powerful was this intervention? And this is a standardized way to kind of conceptualize it. What that means is that on average, these two groups are about 1.5 standard deviations apart from each other at this time point. That's huge. Okay, that's a very, very large effect size. When we talk about Cohen's d, really a 0.8 is considered large. So anything above 0.8 is considered large. We're close to twice that. Okay, just to kind of reiterate this strength of the magnitude. So effect sizes of other types of outcomes. The one all the way on the left here, how many of you know folks who take baby aspirin daily to reduce their chance of having a heart attack? So some of you know folks or may yourselves take baby aspirin daily to reduce your likelihood of having a heart attack. This is based on a study that was done in the 80s that actually was stopped before the study completed because they were finding that there were statistically significant effects of the baby aspirin on reducing heart attacks. So those people who were randomly assigned to take baby aspirin relative to those randomly assigned to take a placebo had a statistically significant difference in the number of heart attacks. Okay? Now, when we're actually talking about the heart attacks, and I want to make sure I get my numbers right, in the aspirin group, 0.9% of that group had a heart attack, and 1.7% of the placebo group had a heart attack. So less than 1% difference between groups. Now, it was statistically significant because they had thousands of families that were in the study. Okay? So when you have a large number of families or participants or subjects, then it's easy to find a statistically significant effect. But the effect size was tiny. The D value here is about a 0.08. Okay? Now let's put that in context to another treatment that many of you probably encounter in your practice or in your research, children on stimulants. So stimulants are widely used evidence-based treatment for children with ADHD. There's some substantial effects on hyperactivity and inattention. And we see a pretty large effect size of about 0.8. But now look at the PCIT study, 1.4, almost twice the effect size of stimulants. So that just helps kind of put this effect size in perspective, because we're talking about a very powerful treatment. So it's not just that we're all saying that we've seen this and we work with these families and we know that this works. We've got the data to prove it. Okay? All right, so a little bit more about the efficacy. So based on these initial efficacy trials, we have some other research showing further support, first of all, in the maintenance. And I know Melanie touched upon this briefly. There were a couple studies that followed families up long term, all the way up until 6 years after they finished treatment. So this is when a lot of the kids are now 12 years old. Okay, and this is really important because when PCIT was developed, really the large rationale is to prevent later adolescent delinquency and conduct problems that can be more severe and very costly to society. So this is demonstrating some support that we know that starting early on in the preschool age can actually reduce the likelihood of children developing into more severe adolescent delinquency conduct problems. Okay? We also have some good evidence that PCIT generalizes to siblings that are not treated. So in some of the studies that were done, we also gave the parents questionnaires about the sibling that was not the, quote, target child, so not the child receiving treatment. But again, as we were talking about before, PCIT is a family treatment. It's a parent training program. We're teaching the parents skills that they can pretty much use with any of their children. And the data support that when we teach parents to use these skills with one child, that generalizes to another child. Okay? We also know, and we have some good support showing that this treatment generalizes to the school setting. Okay? So when we treat these children, we treat them with their families in the home setting, in the clinic setting, with the intention to help families in the home and oftentimes helping them work with their kids in public. We don't typically work with teachers in the school setting, although there is research looking at that, and I'll talk about that shortly. But for the studies where we didn't target teachers, we didn't work with teachers, we still see behavioral improvements in the school setting that generalized from working with the parents. And this is not just based on the teacher's report. And keep in mind, the teachers in these studies, many of these studies, did not know that the children were receiving treatment. They were just asked to report on their behavior. So they were blind to treatment group. They didn't know kids were receiving treatment or not, and they still reported changes. We also had, in some of these studies, observers go to this preschool setting and watch the children and use coding, a different coding system than DPICS to code behaviors in the school setting, and found that those children also displayed significant improvements in their behavior in the school setting. Okay? Finally, there's also been some recent meta-analysis work done that has looked at PCIT. What we mean by meta-analysis is basically studies that review lots of different studies and put them together and try to make some sense. And one of the studies is the Kaminsky study. And by the way, I forgot to mention before, all of these references should be, I think, in your packets. So you should have a list of all these references so you can refer to them. So the Kaminsky study was an excellent meta-analysis where they looked at lots of different parent training programs. PCIT was one of them. And what they wanted to do is they were curious to see what components of these different parent training programs are associated with larger effects. And what they found, if you see the examples here, interestingly, the components of parent training that are in PCIT and actually unique to PCIT, one being the active coaching, which is not typical in most other parent training programs, those are associated with much larger effects of treatment. Also teaching parents how to interact positively with their kids, teaching parents how to use timeout. These are the core components of PCIT and are the ones associated with larger effect sizes. And then there was also an interesting meta-analysis where they kind of took two parent training programs, both PCIT and PPP, which is a widely used parent training program primarily done in Australia, was developed in Australia. And what they did in this study is kind of took a bunch of studies that looked at PCIT and a bunch of studies that looked at PPP and compared them and showed that PCIT was pretty favorable to PPP and actually on a couple of measures had even larger effect sizes. So we're showing comparable effects with other parent training programs, and the components associated with PCIT are associated with much larger effect sizes. Okay. So that's kind of the overall, in a nutshell, the efficacy of PCIT. But research has taken many different directions from those 2 points. And these are questions, I think, that came up already. So some researchers have begun to look at different ways to implement PCIT. The way we'll be teaching it in this workshop and the way you would learn it in a full-length workshop is the standard protocol. And that's working with one family, one at a time, individually, on a weekly basis, until the parent or parents meet mastery criteria and the child's behavior is within normal limits. As we were talking about before, typically on average that is about 4 months, but there's definitely some variability there. But there's been some researchers that are starting to look at other ways to implement PCIT. So for example, in Central Michigan University, Larissa Niech is a professor there who has been doing some pilot work looking at providing PCIT in a group format. And one of the rationales to do this is because PCIT can be expensive. When you're working with one family at a time and one therapist, or even sometimes 2 therapists working with one family, that can be costly. And so these researchers are interested, can we do this in a more cost-effective manner by having 1 or 2 therapists for several families, maybe 4 to 6 families at a time? Additionally, there can be understandable benefits to a group where you have a bunch of parents together who are kind of talking about the stress that their child is contributing to in their family, and they could get support from other families. So there's some reasons why folks think that group may have some benefits to individual. And some of the pilot work that has been done, these are no randomized trials to date yet, but these are some good pilot work studies done looking at PCIT with groups over the course of either 12 weeks or 16 weeks and showing some pretty good effect sizes and some promising results to be able to provide this in a group format. Additionally, there's been some work looking at PCIT in a more abbreviated format. Now, the first one actually was, so typically we say PCIT lasts about 4 months or so until parents meet mastery criteria, but there's been some, albeit limited work, but some work starting to look at, can we do this more quickly? One of the studies done was actually by Michelle Berkovitz for her dissertation, where she provided an abbreviated version of PCIT within a pediatric primary care setting. So to kind of be there where the families are, it was in a group format, and it was a 4-session intervention. I might add, these children were not at the clinically significant range of disruptive behavior. So they didn't have diagnoses. They were kind of at the borderline, kind of in between the normal range and the clinically significant range. So they were at risk. So the real goal of this is, can we prevent the onset of clinically significant behavior problems? And there were some promising findings in that study. Most recently, actually here at FIU, a colleague of mine, Paulo Graziano, has been doing some work providing PCIT in an intensive format. And what we mean by this is, instead of once a week with families, every single day for a little bit of a shorter period of time. This is based largely in the anxiety literature. So in the anxiety literature, we have some work that suggests that diagnoses like OCD and phobias can be treated relatively quickly in a course of 1 or 2 weeks if we see patients every single day and provide an intensive kind of framework. And so we were interested, could we do this with PCIT? So we actually did this here at FIU with 11 families. This has just been submitted, so we're waiting for to see if this gets published. But we found some really remarkable findings. But essentially, this was conducted over a 2-week period. The first week was CDI, and the first phase of PCIT. The second week was PDI, the second phase of PCIT. The children did not have diagnoses, but they did have clinically elevated levels of behavior problems. So we didn't actually do diagnostic interviews with these kids. They were younger kids, but we did screen them on these clinically significant, looking at to see if their behavior is clinically significant. And we found some pretty remarkable findings in terms of the parents' report of the child's behavior, observations, again, of child compliance, and the parents' skills. So we're seeing some promising findings in that kind of work as well. Okay, in addition, we also, many of you, I think, work in the community here in Miami that are here today. And many who are watching the videos probably work with in community settings. And a lot of questions, I think, to bridge this research clinical gap that we always talk about in the literature, that we've got all this research showing this works in clinical research settings. Does it work in community settings? And there's starting to be some studies growing to show, yes, we can do this in the community. We can do this with community providers and community mental health agencies. Yes, we know that there are some barriers, but we can get around those barriers. One of the things that are highlighted in some of these studies is the very high dropout rate. So when families do come to treatment and they participate in PCIT, it's very effective. And in the efficacy literature, we actually see dropout rates around 30 to 40%, which is not very high relative to some other studies. But when we look at the community settings, some of those studies report very high rates of dropout, much more than 50%. So there clearly needs to be more work to be done. But some of the pilot work is showing that for those families that do finish treatment, it can be very effective, and it's feasible to do this in the community setting. Okay? There's also been some work. Amy Herschel is a professor at the University of Pittsburgh at the medical center there, and she does a lot of work on training and studying how do we train people, and does some work with PCIT, and has looked at how do we train community providers. And this is kind of just to reiterate why we're doing all the things that we're doing these next 2 days, is because really what she found is it's not just enough to give a clinician a manual and say, here's a manual, go do this. Or just watch this set of talks on this treatment and go out and do it. She actually found that the experiential component, where we're going to actually all sit down and practice by playing with each other and using these skills together, acting as children, acting as parents, that's what really helps master the skills and be a good clinician. So more work clearly needs to be done in this area in terms of bridging this gap between the clinical research and the community. Finally, in terms of settings, there's been also work, I highlighted, referred to this briefly, is there's been starting to be work done in the school setting. So for many kids, the behavior improvements generalize to school, but not for all kids. And oftentimes sometimes behaviors may continue to occur in the school setting. Sometimes there are specialized school settings that, by nature of the school, have kids that are very problematic, have lots of problematic behaviors. And so there's been some researchers that have actually been going out into the school setting and been training teachers in the same skills that we would be working with parents in. And we actually call this teacher-child interaction training. So teaching teachers how to interact more positively with their students, teaching teachers how to set more firm limits with their students. There's been some actually good research, no randomized trials yet, but some really good preliminary outcome research looking at this, showing some promising findings. I know there's a lot of clinical work being done, and folks are starting to collect data. I know Melanie Fernandez at her site is doing this quite a bit. Chris Campbell at Oklahoma has done this for his dissertation and is doing this work, and I know that should be hopefully coming out for publication. So these are all kind of new and exciting research questions that people are asking, and we're already starting to see some really exciting preliminary findings. Okay, so in addition to the different settings and the different formats of PCIT, PCIT has also been applied to different populations, different diagnostic groups. And these are some questions folks have asked. So one of the first studies on this slide, so what I initially said was in the larger randomized trials, children with any developmental delay were screened out of those studies. And actually that's not unique to PCIT. Most of the parent training literature, the main trials, screen out children with developmental delays. And actually for my dissertation, what I was interested in is, well, those are actually children where rates of externalizing disruptive behavior problems are much higher. If you look at the prevalence rates in kids with developmental disabilities and developmental delays, rates are upwards of 50% in some of the literature that they show clinically elevated behavior problems. So here's a population that has been left out of the efficacy literature. And so what we actually did was we conducted a small randomized trial and found a very similar methodology to the initial outcome studies that I talked about, where families were randomly assigned to treatment or waitlist group. And we found that PCIT was very effective at reducing child disruptive behavior, again, based on both parent report, observation of the child's behavior, parenting stress. And so it was a small trial, but again, PCIT has a very large effect. So we don't need huge trials to show statistically significant effects. Okay? Now, in that study, we actually screened out children on the spectrum, children with autism spectrum disorders, because many of you who work with that population know those children respond differently to social attention than children that are not on the spectrum. Okay? But we also know that the way diagnoses work, it's not like in the real world, it's not like the DSM where you either have it or you don't have it. There's usually a continuum. And so children on the spectrum, they may not respond exactly the same to social attention as kids that are not on the spectrum, but some respond in different ways. So folks are starting to look at this population. And there's been some pilot work being done primarily to date with higher functioning kids. But I know that there is work in progress, and folks are beginning to look at this to see, can this intervention be applied to children with autism spectrum disorders. Okay, so moving along, in addition to developmental delay, developmental disabilities, there's also been some really good work done in the anxiety literature. So if you look at the anxiety literature, we have very strong evidence for children about 7 years and up. Tons of evidence for cognitive behavioral therapy and other related therapies and treatments for child anxiety. When you look at the preschool literature, there's actually much less evidence for effective treatments. So some folks, primarily out of Boston University, have been looking at ways to adapt PCIT to target anxiety disorders in young children and preschool-age children. So the first researcher, Donna Pincus at BU, what she did was developed a kind of an abbreviated version of PCIT where she embedded within that what she calls a bravery-directed interaction, BDI, so a third kind of phase. And that's actually sandwiched in between the CDI and the PDI phases. What it is essentially psychoeducation teaching parents how to do exposures with their children, primarily for children with separation anxiety disorder. So working with families on doing an exposure of leaving their child with a relative, right, and going out to run an errand, and working on that exposure, helping the parent figure out how to do that with their child, because that is an evidence-based treatment for separation anxiety, and so embedding that within PCIT. So she's published some initial outcome studies, pilot studies, showing that this can be effective, and I know that the randomized trial is done and in preparation and about ready to go out. So, so hold your breath on that one, but I know that I've heard the findings are pretty dramatic. In addition to the work in Donna Pincus's work, another one of her colleagues, and actually a new colleague of ours here at FIU, John Comer, has been doing work in a related area, essentially taking not only focusing on separation anxiety disorder, but focusing on kids, preschool-age kids with a variety of different anxiety disorders, not just separation anxiety, but generalized anxiety disorder, social phobia, et cetera, and trying to develop the coaching model and embed these kind of exposures within the actual coaching that makes PCIT so unique. So in the bravery-directed interaction that was primarily done through psychoeducation, in this CALM approach, Comer and his colleagues, what they did was provided CDI, typically CDI. They dropped PDI because they're mainly targeting kids with anxiety disorders, but then they also implemented an exposure module where they're providing active coaching the parents to do the exposures live in vivo. Okay? And I know that the pilot work that's been out has been looking really promising. And also what I do know is I think the future for this anxiety world is for these two programs to merge. There's no need to have two separate programs for anxiety disorders in young kids. So I think the idea is eventually to try to take pieces from both and create a program that combines the elements of both. So some promising work in the anxiety literature. In addition, I think someone asked earlier about ADHD. So there is some support for PCIT and its effectiveness with kids with ADHD, young children with ADHD. One study, the Cronus study, was actually a meta-analysis review. And what that really kind of just talked about is the fact that many of the kids that have already participated in PCIT, primarily for the conduct problems, many of them also had ADHD. And when you look at those symptoms, you see improvements in hyperactivity and inattention, those types of symptoms, along with reductions in disruptive behaviors. But also there was one randomized trial that was actually done in Puerto Rico that looked at kids specifically with ADHD and found that PCIT was effective relative to, again, a waitlist control group, no treatment group among children with ADHD. But that data for kids with ADHD in a randomized trial specifically focusing on that has not been published yet in the United States. So I know that there has been work done in the area, and so we're kind of still waiting for those findings to come out. And in addition to ADHD, there's been a couple other kind of unique populations that this has been applied to. So one, actually, Melanie, Fernandez and I worked with a family of a child who had cancer. That was part of a larger efficacy trial, but a child, 4-year-old, who had cancer who, the behavior problems that were occurring actually were occurring in the medical setting where this child was receiving chemotherapy. And actually, we remember reports of the mom saying the child literally would kind of swing the bag of chemo in the air when he was trying to get his treatment. And so we kind of talk in this case study about how we took this model and tailored it. And so we brought in, for example, a doctor kit and used that doctor kit all in the confounds of PCIT and in the framework of PCIT, but helped this mother increase compliance and increase positive behaviors in the medical setting, in this setting where this child is receiving medical treatment. And most recently, actually, there was an interesting case study done on traumatic brain injury. So there was a child, this was actually done at the University of Florida, child who had a horrible injury from an accidental gunshot wound to the head, and obviously had significant result of that in terms of significant delay and also significant increase in behavior problems. And this case study talked about working with this family and using PCIT to help decrease the behavior problems and show it to be effective. Again, it's a case study, but really interesting applications for PCIT. Okay, so in addition to these other diagnostic groups, I also just want to highlight a couple of other populations that I would consider at risk. So not having diagnoses, but kids that are at risk for either having diagnoses or having other sorts of problems. So the first on there, there's been some incredible work done at Oklahoma, 2 very good, well-designed, large randomized trials that used PCIT for families who were essentially had physically abused their child and was through the DCF system in Oklahoma and were referred to the clinic to receive either randomly assigned to receive PCIT, standard PCIT, or to receive standard care, or they had a third group in this study where they had parents receive PCIT plus they had all these wraparound services, so other kind of services and interventions that were added to the standard PCIT. What they found was actually remarkable. I think the difference between the PCIT group and the standard care group in terms of reoccurrence of abuse was 19% in the PCIT group to about 49% in the standard care group. So, if we think about what happens typically when families are referred to DCF and get treatment, about half of them will reoccur this abuse. If they get PCIT, less than a third, less than 20%, will reoccur physical abuse. So pretty dramatic findings. What was really interesting about this study is when you compared the standard PCIT to PCIT with all these wraparound services, the standard PCIT did better, actually. And it's in some ways it seems counterintuitive because you think if I give more services and more interventions, wouldn't that be more effective? But it's actually consistent with other literature. Sometimes when you add too much, you get too many cooks in the kitchen, you have too much in there, that could actually sometimes water down the effects of the intervention. So we found that, those folks found that in that particular study, the 2004 study. And then in 2009, there was another large randomized trial. What they were looking at in that study was to use a motivational interviewing kind of orientation. And motivational interviewing is kind of a clinical approach used to engage parents, typically used to engage challenging individuals, folks who could be fairly resistant to coming into services. And there's been some evidence for that particular intervention approach. And so this 2009 study actually compared folks receiving that motivational interviewing orientation to folks that did not receive that. And those families who were receiving PCIT and also had this motivational interviewing approach orientation did better. They retained those families more so in treatment than families that were not engaging in that orientation session. So suggesting that, at least with this population, using that kind of orientation, motivational interviewing approach to engaging families in treatment can be effective. Okay, so in addition, there was some work that I did when I was at Brown University with children who were born premature as another kind of at-risk population for behavior problems. So prematurity actually in the United States is pretty high, rates of prematurity, even though we actually have one of the highest rates of all industrialized nations. So we're up to 12.5% of all births in the United States are premature births. And we know that prematurity is associated with potential onset of a variety of different problems, including behavior problems. And if you think about that population, it's almost a perfect fit for PCIT, particularly because families who have a child who was born premature, especially if the child was born very early and very low birth weight, these families are just thankful that their child's alive and made it. And they've been through some pretty traumatic experiences in the NICU, et cetera. And then now that child is a toddler and a preschooler and starting to test limits, these parents have a hard time setting limits because this is their precious child that made it. And so we were really interested in applying this intervention to that population. These children were not diagnosed with the disorder, but they did have clinically elevated levels of behavior problems. And in this study, we had children who were extremely premature. So we had children that were born as early as 23 weeks, about 500 grams, which is about the size of a Coke can. These kids were now 3, 4, and doing fairly well overall, but had behavioral issues. And we showed in that study that, that this intervention approach can be used effectively with this at-risk population of children that were born premature. Finally, in terms of the at-risk study, I just want to highlight some work that I'm currently doing here at FIU, and that is actually working with an infant population, working with babies, essentially, 12 to 15-month-olds. The rationale behind doing this is, as I've just talked about and we're all going to talk about throughout these 2 days, PCIT is very effective. But it's only effective when families come to us and do the treatment and stay in treatment. So we do have dropout. We have sometimes about 30 to 40% in much of the literature. And that's not even including many underserved families that never even go to treatment in the first place, right? So kind of the goal in this work that we're currently doing here is how early can we start to try to get the most at-risk families on the right foot ahead so they may not need PCIT when the child's a preschooler. Maybe we can prevent the onset of these behavior problems. So what we're actually doing is we're here at Miami, we're recruiting families at Miami Children's Hospital, just down the street from here. And they have a very large primary care clinic where they serve primarily families that don't have private insurance, that have Medicaid or just no insurance at all. And they go to this clinic for their regular well visits and sick visits. And we have staff there that approach families who have a child between 12 and 15 months and ask them if they're interested in participating in this program. We are purposely targeting 12 and 15 months because that is the time when children are just beginning to walk and just beginning to talk. And developmentally, that is around the time that these coercive patterns that we talk about in PCIT are just beginning. And these children are just starting to set limits or just starting to explore how much the parents will set limits. So here's a perfect opportunity. These parents are not saying my kid needs help, my child has problems. They're just at risk because of their primarily their income status. And they're at risk for this child exhibiting behavior problems later on. We also screen them with a behavioral measure to see if children are elevated relative to their peers. And then we actually are providing an in-home based approach just using the child-directed phase. As many of you probably would know, using timeout with a 12-month-old, not very developmentally appropriate, right? But we talked about before that timeout is essentially very similar to ignoring. It's just a more extreme form of ignoring. And so using that same approach in the course of CDI, we can help hopefully engage families in using these positive interactions from the start, really early on. We're doing this in the home because we know these families don't have transportation. They're probably not going to come to our clinic, so we know we have to go out to them. And we already published an open trial that's in press that shows some promising findings, and we're just finishing up a randomized trial right now where we're beginning to test this out. So that is kind of sums up the work in terms of families at risk using PCIT and related approaches to target families at risk for problems. Okay, and finally, I mentioned earlier that the two main efficacy trials, and probably most of these other trials with the exception of the infant study I just talked about, most of the families in most of these studies are Caucasian and middle-class families. And as I said before, many of you working in community settings know that's not the most people that you're seeing. And so what lots of folks have been doing is trying to explore, can we use this approach with other diverse cultural groups, both in the United States and in other countries? Okay? One study in particular that's really unique and had a really interesting way to kind of go about testing this was Kristen McCabe and her work at San Diego. And this is for the Mexican-American families that are primarily seeing, do we need to culturally tailor or adapt PCIT to meet the needs for these families? Do we need to change it a little bit to meet the needs of these families? So she actually did some really good work in terms of pilot work and conducting focus groups with families from Mexican-American backgrounds to see what kinds of things would be helpful in treatment. And so she actually developed a modified protocol called GANA. I'm going to butcher the Spanish, but Guiando Niños Activos, which is basically guiding active children, and essentially took kind of some of the feedback that she got from these focus groups. So for example, not calling it therapy, not calling the therapists, but calling them teachers, and wanted to see would those kinds of things, so not huge changes, not changing the core principles of PCIT, but changing these features that may be more relevant culturally for this population, to see if that made a difference. And she actually did a really well-designed randomized trial where families were randomly assigned to either get standard care, get standard PCIT but done in Spanish, or get this GANA approach. Interestingly, what she found is both PCIT and the GANA approach were superior to standard care, but there were no differences between the culturally adapted version and the standard version in the initial study. Actually, if you look at the follow-up study that was very recently published, there was one measure where the GANA program won out. I believe it was in terms of child behavior. So there is some suggesting evidence in that study, actually, that the culturally adapted approach may be potentially more beneficial. But for the most part, the effects were pretty similar. Some of the other work, just to highlight, I already talked about the Puerto Rican study that was done with kids with ADHD that was done in Puerto Rico. The Australian study that was done in Australia, that was one of the main efficacy trials. Very recently, there was a study done in the Netherlands. This was an open trial, so there were about 35 or 37 families or so who all received PCIT. So there was no randomization, no control group, but showing that this was very effective for these families within this country. And then actually recently also in China. There was a study that was done. It was, again, not a randomized study, but there was a control group. So there was some form of comparison, and they found that the families in China who received PCIT reported significantly better outcomes in terms of behavior relative to those who did not get, to kind of those who got no treatments or standard care. And finally, there's a growing list of countries. So these are countries where we know we've trained folks in PCIT. They're doing it clinically. We haven't seen any research published yet, but we know in Norway and Germany and Russia, Japan, and I know probably the list has grown since I last made these slides. So, I mean, we're continuing to explore different countries, different cultural groups within the United States. So research continues. It's very exciting. With that, I think that I have talked well more than enough. I hope I didn't go over. Questions?
Yes. You mentioned earlier that you applied this model to research, you did some research as far as the community setting, and do you find that the level of motivation is very different compared to the clients that come to the clinic?
Well, I think in terms of engaging families can be sometimes challenging in community settings. I bet most of you who are working in community settings can probably speak to this more than I can as a researcher, although I'm starting to do more community work. Yeah, I think that's probably one of the biggest challenges. Certainly there are barriers to doing this work in the community setting. The research has been very limited to date. I know Rhea probably can speak a lot to that because she's doing a lot of training for community providers. So hopefully through the course of these 2 days, we can talk more about that. And I bet many of you probably have concerns with knowing the families that you work with and how to apply this model for those families and what kinds of challenges present. But it's a great question. Because that ultimately is what we want to do. We want to figure out most families in our country receive services. Most of the families in most need are receiving services in community mental health agencies. So we have to figure out how can we extend this research to those settings. That is really one of the most important questions, I think.
I have a question about the group and the studies that were done in the group. Was that just for the teaching phase of the training, or was it for both?
That's a great question. So actually what they did in the group format was they would have the teaching session, again, just like you would individually, where you have actually the group of parents come and do the didactic session with a group of them. For the coaching sessions, generally what they would do is so if you have a family, let's say a group of 4 families, for the coaching, they would start the session typical of just kind of talking about the week with all the families. And then when they start the coaching, one family would start with their child, one parent with their child in the playroom, and then all the other parents would go with the therapist or therapist behind the one-way mirror. And then the other parents would watch that one parent. And then they would rotate. So then the next parent would go with their child. So everyone would be coached a little bit less time than they would in an individual session, but everyone was coached individually with their child. Does that make sense?
Yeah. Process.
Yes. So essentially the format was the same in many ways, just there were more people. I mean, it's almost like if you have multiple caregivers with an individual family, you rotate the caregivers with that one child. In this case, you're also rotating the children because you're not going to have a parent interact with a different child. They're going to interact with their child.
So the parents and the children would be behind the two-way, they'd be observing, and then they would go into their play group afterward, or?
The children won't be observing. So typically, I think what was done is the children would be kind of in a room with like someone who was kind of watching them, like a research assistant who was watching the children with all the other children. Just that one child was in the playroom with their parent. All the other parents would then go behind the mirror and watch that parent and child play and interact.
I'm just curious. The PCIT and comorbid diagnosis, you mentioned that anxiety disorders, that they're looking to merge the BDI and the COM.
Right.
Did they rule out, and also previously it was mentioned about sexual abuse and physical abuse of children, would that not be something that needs to look at first? I'm just kind of curious to see where in the research is that identified or discussed, because anxiety could stem from that, from a traumatic experience or post-traumatic experience.
Yeah, so I know that in most of the research studies that I reported about, most studies screen out children if there's ongoing abuse, if there's concern about physical or sexual abuse. Then in all these studies, those families would be reported to the state as required by law, and usually those families would be screened out. In terms of, I don't know, I'm not sure in terms of previous history in that particular study if they looked at previous history of abuse. I don't think so. They did not. Okay, so that's a good question. I mean, we do know, of course, with the physical abuse studies that we know that this can be effective. In terms of anxiety, I mean, you're right. Some of these families may perhaps have a history of abuse. We don't know, but we know that when they come in and present with anxiety disorders, that those approaches can be effective.
A research item that you're looking to explore within the context of the low-income, at-risk community setting?
Yeah, that's a great question. Probably something that could be really interesting, right, is to think about if you target families really early on, hopefully we're not only reducing the onset of behavior problems, but reducing the onset of potential abuse. So I think that's a great question. The study we're doing right now is not that large scale that we can do that. The challenge with prevention work is you need really large samples, because the incidence rate of abuse, thankfully, is not too high. So you need kind of a large sample to be able to show that, this reduced the occurrence of physical abuse, if that makes sense. But it's a great question. Yes?
2 questions. One is about the session itself. Do you videotape the session? while the parent is with the child in the room and you are on the other side? Do you do a videotaping? I'm asking. Is something that is part of the protocol?
To videotape? Well, in the research studies, yes. Though, I mean, because we oftentimes need that for data. Clinically, I mean, it can be helpful if you have that material, but if you don't, it's not essential. It's not necessary.
No, because the reason for the question was when you pair like some families, and some of the parents can observe the other one, it is an extra element.
Yes.
Because they are seeing something that they may not see on themselves when they are there.
Absolutely, that's a great point.
And the same applies if you videotape. And then you discuss the videotaping with your parents.
And what Rhea was just saying too is part of, if you were going to be going on to further training, part of what would be needed in terms of training is to videotape, because someone who's kind of supervising you and providing supervision to you needs to see how you're doing it, right, in terms of a tape, going back and looking at tapes. But your point in terms of families learning from one another is an excellent point. Even when you work with one family and there's more than one caregiver, and I know in Miami we have that a lot, right? We have extended caregivers very involved in families. So a great thing to get other family members involved, and then when they could watch each other, that's great because they can learn. They may see something that they didn't experience themselves, but they're seeing with that other person and their child.
Or they maybe experience it, but they don't even see it.
Right,
because
right.
That happens many times. And the other one was in connection with the generalization to the school setting. When those research were done, other variables like involvement of the parents, of the personality, or approach of the teachers were taken into consideration?
Not really. Really, the main questions of those studies were, did kids who received treatment also show improvements in school compared to kids that didn't receive treatment? So those are interesting questions,
because
right?
At the same time, of course, those parents have an education in what is important and what is needed, and maybe that is also something that... Yeah.
Right. And I think there are interesting questions to ask in terms of, in PCIT, built into PCIT, you can certainly build in, a conversation with the teacher, right? During treatment, you're working with a family, you can build in conversations with, well, let me talk to your child's teacher and kind of see, what we can help the parents implement in the school setting. So that may or may not have been done in some of the cases. So that certainly wasn't controlled for. It's a great question. Well, thank you for your attention and time.
Thanks, Dan. Hi, y'all. I am John Paul Abner, and there's a couple things y'all need to know about me before I start talking with y'all. The first thing is that I am deep Southern. I am from Cunningham, Tennessee, which nobody has ever heard of. Even folks in Tennessee have not typically heard of Cunningham. And as someone who is deep Southern, there's a couple of things you need to know. One is that I will say y'all a lot. Two is I'm deep Southern, and I live about 20 miles from the International Storytelling Center. And as a result, I have two friends who are professional storytellers, and I am very much a storyteller wannabe. Okay? I'm not really good compared to my friends, but I do like to start presentations off with a story. So I'm going to do that today. And we're going to start off, we're close to lunch, so this story is going to have food in it. We are, which is kind of mean. It is kind of mean. And we're close to Valentine's Day, one of my favorite holidays. And this story is going to have a little bit of romance into it. And I'm going to tie food romance into choosing appropriate populations for PCIT. All right, so first thing you need to know is that my family can cook. They are traditional Southern cooks, and it would not be unusual for me to come home in the evenings from school, and there would be fried chicken, and not deep fried, pan fried, and there is a difference. Okay, one takes 2 minutes, and it's okay. One takes about an hour and a half, and it will just make you drop dead and worship food, okay? And so we've got pan-fried chicken. We have got biscuits. We have got fried okra. We have got fried squash. You notice a lot of fried. We have got mashed potatoes. We got macaroni and cheese. We have got homemade chocolate chip cookies with that smell wafting in. I told you I was going to be mean. wafting in to the living room. And that's what I grew up with, okay? And even though I grew up with that, I graduated high school at 6'4" and a strapping 142 pounds, okay? So my physique roughly resembled that of a yardstick, okay, maybe a beanpole, if you are familiar with those. And so as a result, I'm off to college. One of the things you want to do at college is you want to find love, or at least I did, want to find true love. But at 6'4", 142 pounds, I need a little help, okay? I am not impressing women with my incredible physique. And so I need a little help. So since I come from a food family, what better to do than to learn how to cook? Women like to eat. It's like, if I can cook, maybe it'll impress them. So in comes my Aunt Barb, because my Aunt Barb, okay, she teaches me how to make the most amazing lasagna. Okay, and lasagna is not a Southern food, but Aunt Barb could cook it, and she taught me her secret recipe for lasagna. And I will tell you, Aunt Barb's lasagna was a guaranteed second date. If I cooked lasagna for a young lady, I knew at least I was getting a second date, even if it was just because they wanted to come over and eat leftovers. I was getting this second date. Now, I developed a crush on this young lady. We played volleyball together, and it was one of those things, you got folks you're kind of interested in, then you got folks you are really interested in, and folks that you're just kind of deeply crushed on. Well, I was deeply crushed, so much so that you ever been like crushed on somebody and you really couldn't talk that much around them, right? They kind of just stop your voice, and even though normally you're fairly intelligent and can talk, you get around them and it's like, hi. So I finally got up the nerve. It took me about a month to get up the nerve to come up to her and say, hi, want to come over and have dinner tomorrow night? And she goes, sure. And she goes on to be talking, but I'm not hearing because I'm going, yes, she said, yes, I get to go out with this girl. Okay. And it probably should have in my brain that I should have been listening to her. And I think I even noticed that at the time, but I said, it'd be too awkward to ask. And so I'm really excited. And so I go to start making my lasagna, right? And so I go to make it, and we've got some incredible beef, and we've got sausage, we've got pepperoni, we have got cheese, all kinds of cheese. I can't tell you the ones because that would mess with the recipe. But I will tell you that when I set that lasagna in front of this young lady, and I scooped it out, and the cheese was just coming up in strings where you just knew it was going to be good. And she looked at me and she said, didn't you hear me when I told you I was a vegan? I didn't get a second date with that young lady. And part of it is that my tried and true technique of getting a second date wasn't going to work because I used an intervention that wasn't matched to the population, okay? And so it's very important when you are using an evidence-based intervention to use it for the population that it is been worked, that it's been tested with. And so I want to tell you a little bit about the type of populations that PCIT has a strong evidence base of working, a little bit about why it works with these populations, why it may not work with other populations. I will tell you one of the reasons why I think that PCIT is so effective is that it's so highly targeted. PCIT is targeted for children ages 2 to 7, and that is children ages 2 to 6 years, 11 months, 29 days, 23 hours, 59 minutes, et cetera, et cetera. So we target preschoolers, okay? And it's effective in part because the technique has been designed for preschoolers. Okay? Kids, preschoolers, we'll teach y'all CDI a little bit later on this afternoon. And when we teach CDI, you will see that this is a technique that preschoolers love. Kids, once their parents learn how to do special playtime, kids are going to ask their parents to do special playtime with them. Kids will look forward to it as one of the best times of their day. They eat it up. A 4 or 5-year-old just loves CDI. Meanwhile, a 9-year-old or a 10-year-old might look at their parent and say, why are you talking to me in that way? Right? It doesn't work with older kids as well as it does with younger kids. So it's a really highly targeted population. As Dan was saying, it is targeted for children with disruptive behavior problems. We are working very specifically with kids who have some kind of behavior problems. In order for this intervention to work, the child has to be able to understand simple commands. Tomorrow we'll be talking about how to work with children to obey parental directives better. And in order to be able to do that, they have to understand parental directives, and so they have to be able to understand simple commands. Generally speaking, we are targeting parents who have an IQ above 70. It is possible to do PCIT with lower functioning parents, but there's not that much empirical support because, as Dan was saying, typically those parents are ruled out of treatment studies. And clinical experience from myself and a lot of other clinicians says that working with cognitively low functioning families can be done. It just takes a lot longer. And other interventions may be more appropriate. We also are looking at ECVI scores that are above the clinical cutoff with these. And this is a question that I get a lot of time from community providers who will say, you know, I've got a kid who I think would be ideal for PCIT, but their ECVI score isn't that high. And the answer to that question, and some of y'all are going, what's an ECVI score? You'll find out that. Iberg Child Behavior Inventory, you'll find that out a little bit later in our presentation. And there's some folks that tend to underreport that, most notably parents who are being investigated for physical abuse. Also, foster parents a lot of times have kind of this been there, seen that, done that kind of mentality, and they will underreport. And with the ECVI, if you're doing a research study, you're always using the clinical cutoff. In community practice, private practice, it's one tool to use. Does that make sense? You know, we're not supposed, it's kind of like standardized testing in schools. It's an excellent tool if it's the only thing you're using as a judgment of if a child is appropriate for an intervention. That's not good assessment. Good assessment is composed of multiple tools. But we typically like, essentially with ECVI intensity scores, we like kids who are misbehaving. We like kids who are acting out. A lot of times in treatment, people say, well, this child is a real problem. I think he's too intense for treatment. And with PCIT, we go, yes, those are the kids we like. We like the kids who are ripping apart the waiting rooms. We like the kids who burn things in the bathrooms. These are our kind of kids. And in part, quite honestly, one of the reasons why we have such good effect sizes is that we start with kids who have some really significant problems. And that's what we like with PCIT. So with disruptive behavior disorders, we're looking at oppositional defiant disorder. We're looking for conduct disorder. Oftentimes ADHD is comorbid with this. One of the things that a lot of researchers have noticed, and now there is a pretty strong research basis for this, is that children who have been victim of chronic trauma, most notably physical abuse, they will typically show a lot of these same symptoms as an oppositional defiant child. And that by treating these symptoms with PCIT, you provide a lot of relief for the child and their family. Some examples of disruptive behavior problems include such things as whining, back-talking, noncompliance, lying, hyperactivity, aggression, classroom conduct disorders, tantrums, aggression, cruelty to animals, destructive behavior, my favorite, which is fire setting, stealing. You know, I'm a guy, I'm a pyro. I like those kids who set things on fire. So anyway, there are definitely some factors that will increase the efficacy of PCIT, and these are things that are common to almost any type of parenting intervention. If you have parents who have an average to above average IQ, they tend to learn PCIT faster. If you have parents who are motivated, they tend to work harder than parents who are not motivated. Dan was referring to there's some burgeoning research on kids on the autism spectrum with PCIT, and I'll tell you, you get motivated parents who come in doing their homework every night like they're supposed to, documenting it in detail. And you get motivated parents, and all of a sudden, things just take off quickly. Strong marital support, extended family support. access to child care. All of these things help. With child factors, just having a child, once again, with average to above average IQ or good receptive language skills. And most of you guys are looking at this list and saying, yes, if we had families like that, they wouldn't be showing up for treatment. And I will tell you, in the private setting and in the research setting, you will find these parents and these kids who still have some really strong disruptive behavior problems. In the community, you often find some other things. We have treatment barriers that we like to acknowledge as treatment barriers, but they can be overcome. One of the most tricky is transportation issues. How many of y'all have ever had a client that was coming into treatment well, and then one day the bus is off schedule? Okay. In my neck of the woods, we don't have these things called buses. This is just true. We don't have buses in the mountains. We have cars, and cars for our folks who are living in poverty are often very dicey propositions. Sometimes they start and sometimes they don't. Sometimes they have been repoed. Sometimes their neighbor is borrowing their pickup truck when they did not know their neighbor was borrowing their pickup truck. And so transportation issues can be really dicey from time to time. Court-ordered unmotivated parents can be very tricky. Though I'll tell you, some of my greatest treatment successes have been with court-ordered parents. I want to tell you a story about one of my families, and I'm really going to disguise this for confidentiality purposes, but I was working with a family in Tulsa, and this mother had been sent to me, and she was, how to say this nicely, especially since this is going to be on the internet. She was a strong-looking woman, okay? In fact, there's no other way to say this, but you kind of meet somebody, and you'd like to say that, I'm not scared of anybody, okay? It's just kind of intimidating. And she was just a little strong-looking, if that makes sense. And so, and the reason why she had been referred is that she had had all 4 of her children taken away from her because her 5-week-old had been taken to the hospital and had twist fractures on the child's femur. And so the allegations were that this mom had broken the child's leg deliberately. And so the mother denied it. And so I have an angry, very intimidating mom who is just horrified at the system and has no desire to come into treatment. Now, her children and herself need this treatment. Her children have some significant behavior problems, and she has some significant attachment issues going on with these kids. And so I'm working with this mom, and when I first took this mom in, I said, there's no way. She'll last 2 sessions and she'll quit. One of the hardest workers I ever had in treatment. Once she realized that I was not connected with Child Protective Services and that I really wasn't connected with Child Protective Services, she started working hard. And one of the amazing things about PCIT is that since it's live coaching with the parent, I'm in this mother's ear. And this is a mom who's never had anything good said about her. Recognize that a lot of your clients in the community, when they think about coming to therapy, they think about coming in and having people tell them what they're doing wrong. And so I'm in her ear telling her all the awesome things she is doing and how wonderful she's doing this intervention. And you can see mom's confidence growing, as Rhea said, throughout the treatment hour and over the weeks. When she comes to graduation, it's like mom says, everybody already told me that I wouldn't amount to anything and that I could never finish anything. And she held up her certificate, and this shows that I can. Okay? And we start off with a court-ordered, unmotivated parent who that barrier becomes overcome. It's a difficult barrier to overcome, but it can be done. Parental psychopathology, we're going to see parents who have all types of psychopathology, from affective disorders to anxiety disorders. These always make treatment more difficult, but it is possible. Severe marital discord. One of the things we know with kids with disruptive behavior disorders is that you're more likely to have marital discord. And it's a chicken or the egg problem, right? Sometimes the behavior problems are caused by the marital discord. Sometimes the marital discord causes the behavior problems. But both of them can be problematic. There are some possible rule-outs. You know, we mentioned parents who may have an IQ lower than 70. Can be done, but it's going to be harder, and there's not a lot of research base. Let's talk about some things where you almost always want to rule out. One is if the parent doesn't have access to the child. There are lots of situations where I have had parents court-ordered to PCIT, and they have 1 hour of visitation a week with their child. And I will write to the judge and I will say, Your Honor, if you want PCIT to be done, we have to have more visitation. We can't just do it for 1 hour a week. This is an intervention on the interaction between parent and child, and we can't do it without the kid, okay? So the parent has to have access to the child. A lot of times active substance abuse, if, you know, I had a parent one time who was not making any progress, and she was not making any progress because she was stoned all the time. And I finally had to say, you know, until you can get sober so you can practice these skills, you're not going to be able to master the skills that you need. You really need to go get treatment for your substance abuse problem before you do PCIT. So active substance abuse is almost always a rule. You know, I say almost always. I don't like to say never very often because there's always an exception. But almost always you're going to rule out really active substance abuse. And also parents or kids who have really severe psychotic behavior. You know, you have a schizophrenic mom or you have a child with burgeoning schizophrenia. It could be really challenging to do with PCIT, and that would be a rule out, and especially a rule out for beginning therapists. I would not attempt that in the slightest. You just heard me that I don't like to say never. I'm going to give you a never. Never do PCIT with a child sexual abuse perpetrator. Now, whereas PCIT may be appropriate, and in fact I've done it a lot, for children who have been sexually abused, you don't want to do it with a child sexual abuse perpetrator. Why not? Well, there's two things that we're basically teaching parents how to do in PCIT. The first thing is we're giving them some great skills on how to deepen the attachment between them and their child. And we don't necessarily want to increase the bonding and attachment, you know, to a sexual abuse perpetrator and a child, right? We don't necessarily want to give them that skill set to build bonds to make it to where the child may be more susceptible to sexual abuse. The other thing that we teach parents how to do is how to get their children to comply with them. And once again, that is something we don't really want to teach a sexual abuse perpetrator, is to give them greater skills in being able to get children to obey them. Now, one of the things that's very different about this training, and I'm saying this both to our internet audience and our audience in here, is that because this is a training that we are filming for the internet and we're doing a lot of information, trying to get a lot of information out, we are not as interactive as we normally are in a PCIT training. Typically, when you go to a 40-hour PCIT training or a 30-hour PCIT training after you've done a 10-hour internet training like the one you're doing now, you're not going to sit and listen to people for hours. Everybody's shaking their head no. You're going to be doing a lot of stuff. And so we want to give you, there's going to be several times over the course of today and tomorrow that we're going to give you a flavor of that. And we're about to start to do that now. Because what I want to do is I want to give you some work in choosing appropriate clients for PCIT. So in your packet, you have got a number of scenarios. In your packet, you've got a number of scenarios. And that's correct. Here, I'll go ahead and Vanna this for a second. It has Homer Simpson on the front. This is a copyright image. Hopefully we'll get permission for the internet to use this, but y'all get to use this. And so we've got about 7 scenarios that I want you to take a look through. What I want you to do is get into small groups. Let's say no bigger than 4, no smaller than 3. And y'all are all, at least working on your master's or above, so I'm going to trust y'all to be able to get into groups. No smaller than 4, no bigger than 4, no smaller than 3. But go ahead and kind of huddle up, go through these scenarios. What you got? Hold on one second before. Y'all are doing a great job of huddling up. I'm very impressed with your collegiality. Let me give you the directions. What I want you to do is I want you to go through these, and we're going to use a highly sophisticated method of rating. We are going to use a 1, 2, and 3 rating on them. And Melanie, can you hand me yours because I don't want to get this backwards. So a 1 is this family is absolutely appropriate for PCIT, and there's really no significant barriers or treatment. A number, a 2, is a yes, but there's some things we're going to have to overcome. Number 2 is yes, but there's some things. 3, no. It's like 3 is no, very likely inappropriate for PCIT. So go ahead and huddle up and get into some groups. We just got a great question. Just got a great question. Because typically in a 40-hour training, I've already taught this to people, and that is with ECBE scores, the higher it is, the more challenging the behavior. So 131 is sort of the clinical cutoff. As it goes higher, it kind of gets worse. A score of about 230 is, oh my goodness. Score of 180 is, ah. So here you go. Excellent question. Do all of them. Do all of them. We're having fun. Sam is hard. Yeah. Sam is hard.
1.5. Marital problems.
One of the things that I love to hear, in a PCIT training group is I love to hear this interaction. Love to hear the talking. That is always so exciting to me. So we are going to go ahead and start working on these scenarios. And y'all just stay in your groups. Don't feel like y'all have to turn around to me. We're going to start off with Bart. Bart is 9 with an ECBE of 189. Dad has some difficulty attending sessions, and the children have been placed in foster care due to alleged neglect and abuse. The child is oppositional, disrespectful, lots of temper tantrums, some bullying, frequent detentions at school, talking back to adults. So, what do you think? It's like, who's confident in their answer? We got somebody confident back there.
I would say no, because this is too old. I would just recommend COPE or something.
You would say no, and I would agree with you. It's like this child at age 9 is far too intelligent, and just far too old for PCIT to really work that well. Quite honestly, a kid Bart's age would scoff at some of the interventions. And so we're going to need, and this is where, one of the things I always like to say is that sometimes you get a little competition between the letters. Does that make sense? Between the PCITs and the triple Ps and the ABCDEs and all those kind of things. But recognize different techniques are targeted for different populations. And I would argue that a kid like Bart would probably work better with something like COPE, something like MST, doing something along those lines as opposed to PCIT. So excellent. So we'll go there with a firm answer of 3. Any strong disagreements? Nope. Excellent. Kind of clear cut. Okay, we go to Dennis. Okay. ECBE 172. Parents are awesome, but he's oppositional, destroys property, temper tantrums, talks back to adults, and uses that dreaded slingshot. All right. Who feels confident on this one? All right, feels confident. What do you got? He's a 1. He is appropriate for treatment. Why?
He is in the right age range, showing significant
Excellent. Could not have said it better myself. So we're looking at a definite yes. Now we get tricky. How many of y'all wrestled with this one? It's like, this is the one that the master trainers are having an argument about down here. So number 3 does get a little tricky. Who feels relatively confident with number 3? You've got a smile. Does that mean you're confident?
I'm just smiling.
You're just smiling. Okay.
Well,
All right.
somebody has to go. I put a 2, more towards a 3.
2 more. By the way, I always like it. It's like we have a scale, but we're going to change it.
I'm not going to
Good clinical judgment. Okay.
No, I'm not going to change it, but I have another one that is a 2 that I see it is more towards the 1. So we think that 2, each case is a case. If you're a clinician for many years and do assessment for many years, you know that each case is a case.
Exactly.
So when you go and do like an assessment of a case, you need to take everything into consideration, because this one is a 1, 2, or 3. I will give a 2, but if you ask me, and we'll get into a conversation further than that, I will tell you more towards a 3 than is towards a 1.
Why would you have it more towards the 3?
Several reasons. Number 1 is that IQ of the father is really low. On top of that, he relies on public transportation. So it's not that the conditions are to help him with this low IQ. There is dependency involved. There's foster parents in the picture. So maybe the access is not as easy as it is for other parents that have the children in their custody. So all of that together, I will not say I will rule completely these parents out, because I see that it may be that it's less, it's more slow, as you were saying, with lower IQ. But I don't want to completely rule out, maybe because I work in the dependency system, my population is small.
So you don't want to completely rule them out. In the
I
back.
would say also 3, because they talk about the oppositional behavior is not with the father.
Yeah, they talk about the oppositional behavior. And I'm going to go ahead and I'm going to go full bore 3 on this one. Though I can understand why you would go 2 leaning toward 3. In part because when you do PCIT, you're always thinking, they could really use this part. But I would go full bore 3, and let me explain why. Okay? The reason why I would go 3 with this is not only do we have the father's low IQ, which is a possible rule out, but also when you kind of get into the fine print of this scenario, because this scenario, you get into the fine print and you find that the father and daughter are bonded, and that's one of the things that we're trying to do with PCIT is increase bondedness. And the daughter doesn't act out with him. There's no behavior problems that the daughter is exhibiting. Now, the foster mother, this is my 2, maybe my 2. If I could talk the foster mother into PCIT, that might be one thing. But the dad would probably be better served by a more supportive parenting intervention that's more wide range than PCIT, which is highly targeted. Does that make sense? And so I think for that reason, that's why I would rule him out. Did you have?
What threw me off in this case was the fact that the judge ordered. So obviously,
That's
is there a
so simple.
therapist that perhaps has vast experience in helping families of this context?
Right. Court ordered. Now, unless you have a contract with the court, just because a child is court ordered to a specific treatment does not mean that you are court ordered to provide that treatment. Now, you may be feeling for the parent because they've been court ordered for that, and you may want to help them out, but it doesn't mean that you have to do that. And so part of it, and every once in a while there are agencies that have contracts with the court, and they have to do court ordered treatment, but most therapists don't. One of the things that I like to tell therapists, because one of the things that's going to happen if you become a PCIT providing agency, is eventually the court will hear about it, because they will have a child that has had a wonderful transformation, and the court hears about it. And the court has not been through this particular presentation. Okay? And so they begin to court order inappropriate children into PCIT, and that is a time where you write a nice letter to the judge. If you're in a small town in the South, you take the judge out to lunch and you say, Your Honor, I love the fact that you're excited about PCIT. When you court order somebody, could you please court order them into an assessment to see if PCIT is appropriate or not, rather than into treatment itself? That would really help us out a lot. And I've had conversations and letters with several judges in places who get really excited about PCIT and they start court ordering 11-year-olds into PCIT or kids without behavior problems into PCIT. And it's like assessment. Assessment is a good word. So that is an excellent question. That's actually why I throw that court ordered into there, because I'll get therapists, and particularly young therapists, who get a little nervous when there's a court order involved. And it's important to know what your responsibilities are and are not in that situation. Excellent. In the interest of time, let's go to actually probably my favorite scenario, because I think in many ways this is a scenario that is most similar to cases we see in the community, other than the fact that there's not a small purple monster running around. So we go, thank you for laughing. I thought that was funnier than most folks did. So anyway, so we have Lilo here, okay. Ekbi, she has a score of 157. She is placed with her sister, who's currently unemployed, has missed several appointments. The family's caseworker, Cobra Bubbles, which is the actual name in the movie, doubts the sister's ability to care for Lilo. Lilo allegedly goes into destructive rages. She denies these symptoms, frequently disobeys commands, and backtalks her sister. So what do you think? What have we got here? 2. Excellent. We have a lot of significant barriers to treatment. And these barriers can be overcome, but they're going to take some skill and some persistence, and sometimes a little bit of luck. And one of the things that I like to tell training groups is sometimes training groups will get a little nervous around the 2s with significant barriers. And I'll say, in a community, they're almost all 2s. I do more work with 2s than I do with 1s, right? And I love to get my 1s, I love to get my perfect parents who just need a little help in, love to get them in, because all of a sudden, PCIT tends to go from about 12 to 16 sessions, and with all of those parents who are supportive of each other and intelligent and motivated, we're looking at 12 on the lower end of that spectrum, right? You're looking at about 10 to 12 rather than 12 to 16. But whereas with our community, we're usually looking toward the higher end of that thing. You love to get them in, but the reality is in community work, a lot of our work is going to be with these 2s that have a lot of barriers we have to get creative with. All right, let's go to scenario 5. Huge problems. This kid is capping out the ECBI scale. The mom and dad are having marital issues. The adoptive father wants to keep the child. The mother wants to relinquish parental rights to DCS. The child has had 30 FOSTA-DOT placements and broken them all. He's extremely oppositional, has a lot of conduct problems, from everything to cutting off girls' ponytails to sneaking lawn sprinklers into birthday girl's room, all this kind of stuff. So what do we got here? How about this group over here? We haven't heard from this group back here. What do you say? Everybody's and by the way, everybody's looking. Which group is he pointing to? The group with the young lady with the necklace.
Honestly, say 2 because the dad seems progress, maybe mom. If we see progress, maybe the mom would want to be involved as well. So I say 2. Even though I don't go into one of 13, I think.
So you're saying 2. And I think 2 is very accurate in this case. Yes, ma'am.
I would say 1 only because I think that the mom is giving up because she really doesn't know or have the tools to deal with the situation. And I think that when she did, like that situation you said about that mother that, with her 5 kids, I think that would probably motivate her. I think that would be a really good.
And I think as a therapist, seeing this case as a 1 is great, because that's a very optimistic view of the case. And quite honestly, I think in PCIT, optimism is a powerful and potent thing. I think in any treatment, optimism and hope is a potent treatment thing. I do see their marital problems as being a significant barrier. And I might, quite honestly, with a family like this, I would probably have them doing PCIT and marital therapy at the same time. I will tell you, and one of the reasons I include this scenario is working with the Centers of Excellence for Children in State Custody. We get a lot of kids that the foster-adopt parents have essentially given their notice that they are going to give the child up. And we have saved at least 7 of those in the last 2 years. Okay, and that's really cool. It's really cool when you have this foster-adopt parent who was saying, there's no way we can keep this child, and then 3 months later say, we love this child, and we want to keep this child. That is a beautiful thing. All right, let's go to Calvin. Calvin, what do we got with Calvin? What do we got? 1. Extremely clear cut. No really significant behavior problems. No real significant boundaries. All right. Excellent. Now let's go to what is my favorite, Rapunzel. All right. Rapunzel's a little tricky. This one's a little tricky. Who is brave enough to tackle the Rapunzel problem? Who's sort of brave enough to tackle the Rapunzel problem? I'm going to go. Actually, no. I'm going to go with the Master Trainer. I want to hear from you guys. What have y'all got on Rapunzel?
I think our first question is this actually, are we considering Rapunzel at age 4, or are we considering her as she is in...
We're considering her at age 4. We're considering...
Are we aware of the kidnapping or not aware of the kidnapping?
It's like you can, apparently you're not aware of the kidnapping since you would report that to the state. So what have you got? This one's tricky.
I'd probably say a 2. I'm concerned about teaching, or I'm concerned about the mother's desire to keep her daughter obedient and stay inside. You know, part of the treatment would also be helping her to set more developmentally appropriate expectations for the child.
Okay.
It is hard to access care when you live in such a remote area. Have trouble getting transportation.
That's right. When you're locked in a tower, it's hard to get out.
And it seems like she's also a pretty obedient kid.
I was actually leaning towards 3 myself because I'm not getting a sense of any real behavior problems beyond leaving the house. That's a very specific problem, and I like to say that sometimes PCIT is like a cast when all you need is a Band-Aid. And for me, this is more about just talking with mom about close supervision and maybe some rewards for staying inside the house.
Staying inside the house. All right, I'm going to go, and by the way, this one's a bit tricky because if you've watched the movie, okay, you know that mother's actually an evil witch who's keeping her inside to cut off her magic hair. And so with a little bit of that knowledge, I go with the 3. The Melanie kind of pinhole. Do you know about the kidnapping? Well, I guess you can't know about the kidnapping. But essentially, using just what I know, this is a child who's not showing any behavior problems. And keeping a child indoors is especially in a rural environment, is not a very developmentally appropriate thing to do. It's almost... This is probably my farm boy orientation coming out. It's quasi-abusive. And so I kind of have this as sort of my abuse scenario. Because if I said, okay, mom is sexually abusing the child, you'll say no. So I kind of have, okay, mom is using the child to cut off her magic hair. Yeah, no, it's like that's an inappropriate reason to do that. All right? So a little tricky on that last one. And I always tell my workshop participants that it's okay if you didn't get that one wrong. I actually tell folks when you're looking at this, other than some of the ones in that the obvious 3, there's going to be a little bit of difference, but you can hear the agreement in the room between folks saying, okay, this is a 2 leaning toward a 1 or a 1, or this is a 2 leaning toward a 3 or an obvious 3. You hear that agreement in the room, which is a really nice thing to listen to. All right, well, you guys did a great job. That's actually one of the initial core competencies of PCIT, is being able to define an appropriate population. If you have questions about this exercise, I'd be happy to answer that afterwards, but I have found that a speaker's ratings goes down significantly when you hold people in late from lunch.